it's Rep Baker, and I just introduced House Bill 362 that has to do with CRNA practice. CRNA stands for Certified Registered Nurse Anesthetists, and they're providers who complete an undergraduate nursing degree and a graduate degree from a CRNA nursing program. Many of these programs also require that the students work clinically as a nurse in an ICU or critical care for a certain amount of time before they're admitted into the graduate program. CRNAs provide anesthesia for patients receiving care from surgeons. They also do epidurals for obstetricians, anesthesia for GI docs doing colonoscopies, podiatrists, pain specialists, and many others. In Ohio, there's over 3,600 CRNAs and nearly 150 facilities in Ohio where CRNAs are the sole anesthesia provider. This enables these facilities to offer anesthesia services to underserved communities where other anesthesia providers are rare. While there are lots of CRNAs, Ohio ranks among the most restrictive and outdated regulatory environments for CRNAs. Currently, our code requires that they are supervised and under the direction of a physician, podiatrist, or dentist. Interestingly, our code does not prescribe what supervision entails, so there's no requirement that the supervising physician be there on site. And then a final issue is that only anesthesiologists are able to bill to supervise CRNAs. So the issue is that most CRNAs are not supervised by anesthesiologists, so the supervising providers often have less anesthesia education, have unclear regulations about what their supervision must entail, and are not reimbursed for being in this role. 43 states no longer have supervision requirements for CRNA practice, and out of the remaining states that do have it, only 2 states, Ohio and Louisiana, have language as restrictive as Ohio's. So the goal of this legislation is to eliminate these arbitrary barriers to practice for CRNAs and allow them to practice at the top of their education and credentialing by removing the supervision language and instead creating a consulting relationship between CRNAs and physicians, dentists, and podiatrists. The changes in this legislation would more closely align the code with what currently is happening in clinical practice in Ohio. The legislation also contains no mandate. It just allows for a consulting relationship. So, for example, if an individual surgeon or if a hospital system doesn't want their CRNAs to practice without supervision, they can absolutely write that into their institutional policies. The legislation just aims to increase options and allow systems and practices that are comfortable with CRNA consulting relationships to use this without a supervision mandate, increasing access to CRNAs to provide safe, high quality, and cost-effective anesthesia care for their patients.